Hello, it's Mark Chris again, continuing our discussion on advances in the treatment of patients with early stage lung cancers. In the earlier discussion, we talked about the appropriateness of either neoadjuvant nivolumab with chemotherapy, followed by surgery, or surgery followed by cisplatin-based chemotherapy, then followed by nivolumab. I think both of these regimens are FDA approved. They require, I would say, expression of PD-L1, though that is not explicitly stated in the nivolumab approval. And they also would be best for patients that do not have ALK rearrangements or VEGFR mutations. Both are important advances in therapies. They can enhance cure. So which do you choose, adjuvant or neoadjuvant? And I'm going to make the case that neoadjuvant is the preferred approach. And exactly why is that? Well, number one, what is the risk to these patients, the risk to their life? It is metastatic cancer. And in that setting, it makes most sense to give them an agent targeting metastatic cancer as quickly as possible, and that would be the neoadjuvant setting. The second advantage of the neoadjuvant approach is that you can assess the actual benefit of chemotherapy in these patients by monitoring their scans, their progress. You can tell if that therapy is working. It can be discontinued if ineffective. It could be changed, and there's data to support that. Also, if it was ineffective. It also gives you a hint about the appropriateness of that therapy, where to use it in the adjuvant setting, but that's another advantage to that. In general, neoadjuvant therapies are much better tolerated, and it also gives you time to learn more about the person you're taking care of, comorbid illnesses, or unfortunately, often undetected metastatic disease. In addition, it gives you the opportunity, by examining the resection specimen, to estimate the benefit of that regimen. It's been shown in the trials that have been done to date that pathologic response, particularly pathologic complete response, is a potent predictor for that patient of disease-free and overall survival. So that's an important piece of information in taking care of that patient. The second thing is, if you're in the drug development business, it gives you the opportunity in just a few months to know if a drug has potential usefulness long-term based on its success. The data to date says that. More data is being amassed to try to prove it more definitively. There are advantages to adjuvant therapy as well. The first is the patients there are absolutely precisely staged. Please remember, staging is surgical staging, which can only be done at surgery. It also gives you ample tissue to test. Sometimes that's not always the case with the diagnostic specimens at the beginning of treatment, but you have tissue and you have time as the patient rehabilitates from surgery. And the third thing that I think is an advantage for the adjuvant approach is with targeted therapies, patients with EGFR mutations. Today, that's the approved category, and I think other targeted therapies will be shown to be beneficial in the future. There, I think it makes most sense to continue those for longer periods of time, and it makes the most sense to do that in the adjuvant setting. Our model here are GIST tumors, and in general, the longer the imatinib was continued in adjuvant therapy for GIST tumors, the better results. So, adjuvant and neoadjuvant approaches, both appropriate. I would favor neoadjuvant for the reasons that I said. And we now have both available to us for patients that are operable, resectable, and have no mutations in EGFR or ALK rearrangements, and have some expression of PD-L1.